All right, guys, so we're starting chapter 19, Introduction to Nerves and Nervous System. Some important key terms you need to know. Start here, the forebrain. You need to know that the forebrain is responsible for thinking and coordination. It contains the hypothalamus and the thalamus. Midbrain, responsible for arousal and sleep, wakefulness. Neurotransmitters, chemical produced by a nerve and released when the nerve is stimulated, reacts with a specific receptor site to cause a reaction. All right, the nervous system is responsible for controlling the functions of the human body, analyzing incoming stimuli, and integrating internal and external responses. Please jump to page 332. Neurotransmitters. Neurotransmitters stimulate postsynaptic cells either by exciting them or inhibiting, stopping them. So let's talk about the different neurotransmitters. You guys absolutely need to know them, okay? Acetylcholine communicates between the nerves and the muscles. Epinephrine and norepinephrine. These are catecholamines which are released by the nerves. These are your fight or flight catecholamines. These give you the energy to fight or flight. Somebody tries to rob you. Are you going to fight them off or run away? Either way, you're going to need that energy, right? Norepinephrine and epinephrine. So I put this on the side because I couldn't find it in the book, but you need to know that. When it comes to epinephrine and norepinephrine, remember, fight or flight response, blood pressure elevated, heart rate elevated, glucose increased. Remember, it's the oxygen, vitamins, minerals, nutrients that are carried in the blood that are feeding your cells to give you the energy to do what you need to do, fight or flight. Dopamine. I put a star next to dopamine. You know that's going to be on a test, right? Dopamine is involved in the coordination of impulses and responses, both motor and intellectual. Those with, and we'll get into that, but those with Parkinson's, it's a decrease. They don't have enough dopamine. GABA, this is found in the brain, and it inhibits, it stops nerve activity, prevents overexcitability or stimulation such as seizure activity. Gabapentin. All right, serotonin. This is our feel-good neurotransmitter, right? Serotonin is found in the limbic system. It's important in arousal and sleep, as well as preventing depression and promoting motivation. This is our #1 go-to antidepressant. You're going to learn more about this medication when you get to psych, but you definitely need to know serotonin. Can I turn the page? A short chapter. Okay, summary, important things. Did we? No wonder. Oh, okay, thank you. Jump over to page 335, please. Midbrain. So the midbrain, it sits above the hindbrain. In a small area, it contains cranial nerves related to specific senses, such as your sight, your smell, hearing, balance, taste, and some muscle activity of the head and neck, such as chewing, eye movement, and the reticular activating system, that's the RAS, which controls arousal and awareness of stimuli and contains sleep center. That was the midbrain. Now we're going to talk about the forebrain. The forebrain, and I wrote this down because I didn't see it in the book, but you need to know this for testing purposes. The forebrain is located in the upper level of the brain. That contains two cerebral hemispheres, the thalamus, hypothalamus, and the limbic system. The thalamus sends direct information into the cerebrum to transfer sensations such as cold, heat, pain, touch, and muscle sense. Areas of the hypothalamus are responsible for temperature control, water balance, appetite, fluid balance. The limbic system, it contains high levels of 3 neurotransmitters. What are those neurotransmitters? Epinephrine, norepinephrine, and serotonin. Stimulation of this area of the limbic system, which appears to be responsible for the expression of emotions, may lead to anger, pleasure, motivation, stress, and so on. And down here I wrote cerebral cortex, your 2 hemispheres. They're responsible for speech, communication, thinking, and learning. And the reason I wrote this down, I couldn't find it in the book, but I've seen this pop up on NCLEX every once in a while. Speech, communication, thinking, learning. Okay. Key points. CNS consists of the brain and spinal cord, which are protected by bone and meninges. Summary, I'm on page 338. Efferent nerves. When you see that EFF, efferent nerves, think away from, okay? Efferent nerves takes information away from, out of the CNS to the effector sites. Afferent, AFF, afferent nerves are sensory nerves that take information into, towards the CNS. The CNS consists of the brain and spinal cord. Again, they're protected by bone and meninges. To ensure blood flow to the brain if a vessel should become damaged, the brain also has a protective blood supply moderated by the circle of Willis. You guys learned about that in A&P. The limbic system. The limbic system is responsible for the expression of emotion, and the thalamus and hypothalamus coordinate internal and external responses and direct information into the cerebral cortex. Speaking of the cerebral cortex, remember it has 2 hemispheres. They regulate communication between sensory and motor neurons, and they are the sites of thinking and learning. All right, chapter 20, anxiolytics and hypnotic agents. The first drug cards you're going to give me next week are going to be your benzos. Benzodiazepines that are used as anxiolytics, because remember, I think I talked to you guys about this last week, where you can have a certain medication where it's part of one drug class, but it can be used to treat something else in another drug class, okay? So look at our benzos. That's going to be number 1, your diazepam, lorazepam. Second drug card I expect from you, barbiturates. Barbiturates used as anxiolytic and hypnotics, because this is what we're going to be talking about in this chapter. Your pentobarbital, phenobarbital, secobarbital, Barbitol. Drug card number 3 is going to be your other anxiolytic and hypnotic drugs. And I put a star next to the 2 that, oh, I missed one, actually 3 that shows up the most for testing purposes. That's your buspirone, your promethazine, and your zolpidem. Make sure that you recognize that. Okay, I'm going to scroll up a little bit to go over the key terms. Buspirone, promethazine, zolpidem. No problem. All right, key terms, make sure you guys know your anxiolytics. These are drugs used to depress, slow down the CNS system. It prevents or reduces the signs and symptoms of anxiety. Hypnotics, these are drugs used to depress or slow down the CNS, and they cause sleep. Anybody else have another med search book with that? No. I'm being greedy. No, you're good. Okay, page 342, hypnosis. So hypnotics are used to help people fall asleep by causing sedation. So you already know all of a lot of nursing interventions you're going to be doing for this patient safety and a lot of teaching, right? Patient that's on hypnotics, you think they should be getting in their car and driving? No. So let's start with the benzodiazepines, which for today's class, for these purposes, they're being used as anxiolytics and hypnotics. So benzodiazepines, the most frequently used anxiolytic drugs, prevent anxiety, look at this, without causing much associated sedation. So this is great. It can decrease the person's anxiety without us worrying about the sedative effects, right? In addition, they're less likely to cause physical dependence, which is wonderful. Than many of the older sedative hypnotic that are used to relieve anxiety. So this is great. We don't have to worry about those sedative effects much, and we really don't have to worry about dependence. They're not as addictive as other drugs on the market. They have the potential to be addictive, but not as other drugs on the market. Benzodiazepines that are used as anxiolytics. Xanax, alloprazolam. You know I'm not good at pronunciation. So make sure you guys know the generics, as always. Clonazepam, diazepam, lorazepam. Therapeutic actions and indications. When it comes to the benzos are indicated for the treatment of the following conditions: anxiety disorders, alcohol withdrawal. Remember, guys, alcohol withdrawal is potentially lethal, right? What's that?
Alcohol and benzos
For withdrawal. I did not know that. I have to think about that for a second, but I did not know that. Hyperexcitability and agitation, pre-op relief of anxiety, and intention to aid in balanced anesthesia. And on the side, I wrote, it makes GABA more effective. You guys need to know that. The benzos make GABA more effective. And for testing purposes, you guys are definitely going to see psych, so I'm going to tell you now. When it comes to alcohol withdrawal, one of the first line drugs used for that patient is going to be a benzo. You're going to expect the doctor to order that, okay? The exact mechanism of action, though, guys, is not clearly understood. We know it works, but we don't know exactly how. Contraindications and cautions. I'm sorry, it froze. I can't move this. I have to move the book. If I move this, it freezes. That's too bright. Okay. All right, contraindications and cautions. Obviously, allergy. If the patient has an allergy to benzodiazepines, you're not going to give it, right? Psychosis. If they are out of their minds, this means they are out of touch. When you see psychosis, that means out of touch with reality. That is a contraindication. Acute narrow angle glaucoma, shock, coma. Acute alcoholic intoxication. That means right now at the moment, they are severely intoxicated. You can't give them a benzo. Do you give any medications with alcoholism? Absolutely not. You guys know that. Pregnancy, breastfeeding, you're going to use with caution in the elderly or debilitated patients. And you guys know why. Their kidney's not working the way it used to. Their liver's not working the way it used to. So they're at highest risk for toxicity. Renal hepatic dysfunction. All of these drugs now have a black box warning that concomitant use with opioids can result in profound sedation, respiratory depression, coma, or even death. Let's look at cultural considerations. Special care should be taken when anxiolytic or hypnotic drugs are given to African Americans. About 15% to 20% of African Americans are genetically predisposed to delayed metabolism of benzodiazepines. What does that tell you? If they're more prone to delayed metabolism, what does delayed metabolism tell you? Risk of what? Overdose, toxicity. So you have to be careful, okay? As a result, they may develop high serum levels of these drugs with increased sedation and increased incidence of adverse effects. If an anxiolytic or hypnotic agent is a drug of choice for an African American individual, the smallest possible dose should be used and the patient should be monitored very closely during the first week of treatment. And then what happens is it will be increased as needed, but we're going to start at the lowest dose. Yes, ma'am. All right, who's going to send me the email to switch this one out? I have like 5 of them. Just for incident. Thank you. What's that?
Just bring them all.
Bring them all. Adverse effects. The adverse effects of benzodiazepines are associated with the impact of these drugs on the CNS and the peripheral nervous system. Nervous system effects include sedation, drowsiness, depression, lethargy, blurred vision, sleep driving, and other complex behaviors, headache, apathy, lightheadedness, amnesia, and confusion. In addition, mild paradoxical, remember I told you about that word, it means like ironically, because we're going to see the opposite effect, okay? Mild paradoxical excitement. Excitatory reactions may occur during the first 2 weeks of therapy. And so that's so weird because it's supposed to be depressing, right? But we might see a paradoxical reaction, which is the exact opposite where we see excitement. And so you have to warn them. You have to warn them because if this happens to them, they'll say, oh, this doctor's a quack, this nurse practitioner's a quack, I'm not going to take this medication anymore. So you have to warn them that this may possibly happen within the first 2 weeks. Other adverse effects, GI effects such as dry mouth, constipation, nausea, vomiting, cardiovascular effects such as hypotension, hypertension, arrhythmias, palpitations, respiratory difficulties, hematological conditions such as blood dyscrasias and anemia are possible. Genitourinary effects such as urinary retention, hesitancy, loss of libido. That's an important one to teach, especially to the men, because you know they'd rather die before losing this, right? Wanting to do this. So you got to teach that to the patient. Abrupt cessation of these drugs may lead to a withdrawal syndrome characterized by nausea, headache, vertigo, malaise, and nightmares. You need to know this. This list, you just saw this. If they abruptly stop taking these medications, remember that word syndrome, that means just a cluster of signs and symptoms that you'll see. This is it right here. Nausea, headache, vertigo, malaise, nightmares. You have to teach that to the patient. And guys, when it comes to psych meds across the board, you never discontinue abruptly, ever. Drug-drug interactions. The risk of CNS depression increases if the benzodiazepines are taken with alcohol or other CNS depressants such as opioids, so such combinations should be avoided. And you guys know this. I know in the movies and TV, you know, people get drunk and they're excited, they're partying, but alcohol is a depressant. It is not a stimulant. It is a CNS depressant. The effects of benzodiazepines increase if they're taken with cimetidine, oral contraceptives, or disulfiram. Finally, the impact of benzodiazepines may be decreased if they're given with theophyllates. Adverse effects of benzodiazepines. When a benzodiazepine is inadvertently administered intra-arterially, arterial spasms may occur, which can ultimately lead to gangrene. That person can lose that extremity that you gave them the benzodiazepine. So do we ever give benzodiazepines intra-arterially? No. Avoid it. Nursing considerations for patients receiving benzos. You're going to assess them for any allergies to benzos, impaired liver, kidney function, any condition that could be exacerbated by depressive effects of the drug, such as, remember those contraindications, guys? Glaucoma, coma, psychosis, shock, acute alcohol intoxication. Pregnancy, lactation, you're going to get a baseline on them, vitals, check, monitor lab tests, implementation rationale. Do not administer intra-arterially. That patient may lose that extremity. Monitor injection sites carefully. Do not mix IV drugs in solution with any other drugs. That benzo is given in a line by itself. Give parental forms only if oral forms are not feasible or available, and switch to oral forms as soon as possible. Give IV drugs slowly, because these agents have been associated with, remember, it depresses, right? Hypotension, bradycardia, and cardiac arrest. Arrange to reduce the dose of narcotic analgesics, and closely monitor the patients receiving benzos. And it makes sense because narcotics, do they stimulate or depress the CNS? Depress. Maintain patients who receive parental benzodiazepines in bed for a period of at least how long? 3 hours. Do not permit ambulatory patients to operate a motor vehicle after an injection. You want to ensure safety. Monitor the hepatic and renal function as well as CBC. Why CBC? What is the possible adverse effect that we're going to be looking at the CBC? Remember the blood dyscrasias? Remember that? So we're going to be looking at the RBC. We're going to be looking at the hemoglobin, right? Taper dose gradually after long-term therapy, especially in epileptic patients, because when you DC any CNS drugs, any psych meds, you put that patient at risk for seizures. That's one of the first things that can happen, right? But especially in a patient that already has history of seizures, your epileptic patients. That's been seen on NCLEX too many times to count. Make sure you know it. Anything, guys, that I put a star next to, or I write NCLEX next to, you should have it in your book. It would be wise of you, because remember, after you take this class, you're still going to go back and review. All right, you're going to provide comfort measures, environmental control, lighting, temperature, stimulation. You're going to make sure the patient has soft lighting, right? Take safety precautions such as the use of side rails. When they can ambulate, you're going to make sure you assist them with ambulation. We don't want any falls. Page 348. Teachings for the patient, dizziness and drowsiness. You're going to teach them to avoid driving or performing hazardous activities, nausea, vomiting, and weight loss. You're going to teach them small, frequent meals. Constipation and diarrhea, teach them that it usually passes with time, but if it does not, to contact their healthcare provider. For vision changes, slurred speech, or unsteadiness, teach them that these effects will also subside with time. Take extra care in the activities in the first couple days. If these reactions don't go away after the first 3 to 4 days, you're going to teach them to contact their healthcare provider. Teach them to report any of these following conditions to the healthcare provider. What are those conditions? Rash, fever, sore throat, insomnia, depression, clumsiness, nervousness. Avoid the use of over-the-counter medication or herbal therapies without getting them approved from the healthcare provider. Avoid alcohol while on these meds, and do not stop taking these meds abruptly. They have to be weaned off. Key points. Anxiolytic drugs such as benzodiazepines depress the CNS to diminish these feelings. CNS depressants such as sedatives induce drowsiness, as do hypnotic drugs, which also depress the CNS and inhibit neuronal arousal. Hypnotics react with GABA inhibitory sites to depress the CNS. They can cause drowsiness, lethargy, and other CNS effects. All of this to say, you better be thinking safety. Okay, you're going to provide safety measures for your patient. All right, do you guys need a break before we get into the barbiturates used as anxiolytic hypnotics? Yes? Okay, let's take a 10-minute break. Okay, guys, barbiturates used as anxiolytic hypnotics. I'm on page 348. So barbiturates. Barbiturates were once the sedative hypnotic drugs of choice. Not only is the likelihood of sedation and other adverse effects greater with these drugs than with the newer sedative hypnotic drugs, but the risk of addiction and dependence is also greater. And that's why it's no longer the drug of choice. For these reasons, newer anxiolytic drugs have replaced barbiturates in most instances. The barbiturates used as anxiolytic hypnotics include butalbital, pentobarbital, and phenobarbital, also secobarbital. All right, therapeutic actions and indications of the barbiturates. Barbiturates are general CNS depressants. They can cause sedation, hypnosis, anesthesia, and in extreme cases, coma. In general, barbiturates are indicated for the relief of the signs and symptoms of anxiety and for sedation, insomnia, pre-anesthesia, and the treatment of seizures. Contraindications and cautions. Obviously, we're not going to give a barbiturate to anyone that has an allergy to them. But also previous history of addiction to sedative hypnotic drugs. And you guys saw I put NCLEX next to it. However, let me tell you something. Let me tell you how they've presented it on NCLEX in the past. I know the book says previous history of addiction to sedative hypnotic drugs, but on NCLEX, the way they present it, they'll give you a situation about a patient, and then their history is alcoholism. That's a type of addiction, right? It doesn't matter. If they have a history of addiction, we're going to withhold that medication and place a phone call to the physician. Say, hey, I noticed you ordered a barbiturate, but this patient has a history of addiction. Do not just blindly give that medication. All right. So anyway, addiction, latent or manifest porphyria. What's porphyria? Somebody look that up for me. Porphyria. And I know I've asked this question every semester, and I always forget. What's that?
A group of liver disorders.
A group of liver disorders. Okay, that makes sense because we need the liver to metabolize the medications, right? Makes sense. Hepatic impairment or nephritis, respiratory distress, severe respiratory dysfunction, pregnancy, congenital abnormalities have been reported with barbiturate use. So can a person take barbiturates if they're pregnant? No. Use with caution in patients with acute or chronic pain because barbiturates can cause a paradoxical excitement. Masking other symptoms. We're not going to give barbiturates to patients with seizure disorders, chronic hepatic, cardiac, or respiratory disease. And care should be taken with lactating women because of the potential for adverse effects of the infant. Let's talk about adverse effects of barbiturates. As previously stated, the adverse effects caused by barbiturates are more severe than those associated with other newer sedative hypnotics. So for this reason, barbiturates are no longer considered the mainstay for the treatment of anxiety. We have way better meds on the market. The most common adverse effects are related to the general CNS depression. Drowsiness, somnolence, lethargy, ataxia, vertigo, feeling of having a hangover. GI signs and symptoms, nausea, vomiting, constipation, cardiovascular effects, bradycardia, hypotension. Serious hypoventilation may occur, so you better be doing those respirations. Respiratory depression and laryngeal spasms may also result, particularly with IV administration. Hypersensitivity reactions include rash, serum sickness, and Stevens-Johnson syndrome. This is fatal. NCLEX expects you to know that. Drug-drug interactions. Increased CNS depression results if these agents are taken with other CNS depressants, including, this looks like a beautiful select all that applies to me, guys, alcohol, antihistamines, and other tranquilizers. There's often an altered response if phenytoin, that's Dilantin, if it's combined with barbiturates. If barbiturates are combined with MAOIs, you're going to learn more about the MAOIs when you get into psych, but if they're combined with the MAOIs, increased serum levels can occur. And think about it, if increased serum levels occur, What do you think that'll do to the blood pressure? Blood pressure will go up or down more? Down more. Heart rate will go up or down more? Respirations will go up or down more? Okay. In addition, because of an enzyme induction effect of barbiturates in the liver, the following drugs may not be as effective as desired. Look at this list, guys. Oral anticoagulants, digoxin, TCAs, corticosteroids, oral contraceptives, estrogen, the list goes on. So when it comes to the barbiturates, guys, you need to think safety, 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 safety. Nursing considerations for patients receiving barbiturates. Assess them for any known allergies. History of addiction. Ding, ding, ding. Make sure you know that. Hepatic or renal function, cardiac dysfunction, respiratory dysfunction, seizure disorders, acute chronic pain disorder, pregnancy or lactation. Implementation rationale. When it comes to the barbiturates, do not administer these drugs also intraarterially. It can cause gangrene and they can lose that extremity. Do not mix IV drugs in solution with any other drugs. Switch to oral forms as soon as possible. Give IV medications how? Slowly. Are you guys awake? Or are you worried about your test later? You got this. You guys are all going to do great. Taper the dose gradually after long-term therapy. Remember, when it comes to these CNS meds, they're never DC'd abruptly, ever. Key points. Barbiturates are an older class of drugs used as anxiolytics, sedatives, and hypnotics. They are not our first-line treatment. All right, other anxiolytic and hypnotic drugs. These are the others that you need to know. Let me bring this to your attention. For the buspirone, okay, it has no sedative, anticonvulsant, or muscle relaxant properties. It reduces the signs and symptoms of anxiety without many of the CNS effects and severe adverse effects of other anxiolytic drugs. And for all these other drugs, guys, I just highlighted the names. I just highlighted the names. Oh, you need the top? Yeah.
Does that say no by antihistamine?
Yes. Antihistamines can be very sedating in some people. They're used as pre-op medications and post-op to decrease the need for narcotics. Can I turn the page? Page 353. Xalapron and Zolpidem. Your Sonata and Ambien, both which causes sedation, they're used for, and that's your key, short-term. Short-term treatment of insomnia. Summary, anxiolytics, they treat anxiety by depressing the CNS. Sedatives may cause drowsiness, lethargy, and other effects. Hypnotics further depress the CNS. Benzodiazepines are a group of drugs used as anxiolytics. They cause drowsiness, lethargy, and other CNS effects. Barbiturates, those are an older class of drugs used as anxiolytics, sedatives, and hypnotics. They're associated with potentially serious adverse effects and interact with many other drugs. You guys saw that long list. They're less desirable than benzodiazepines or other anxiolytics. Buspirone, another anxiolytic drug, does not cause sedation, or muscle relaxation. Relax. I can't put relax. Thank you. Relaxation. That's why I put a happy face next to it. Newer hypnotic agents such as your Zaloplan and your Zolpidem affect melatonin levels. And so on the side, I put sleep. But are they used for short term or long term? Short term. Very good. All right, chapter 21, antidepressant agents. Key terms you need to know. Affect. You cannot feel affect, you can see affect. So you can kind of tell if the person's happy, sad, angry, frustrated, annoyed. Affect, this is the feeling that person experiences when he or she responds emotionally to the environment. But when you are seeing the person, you're looking at their affect, you're looking at what they feel on the outside, it should show on their face. Patients should not have a flat affect where you cannot read them at all. Okay? Depression. Let me tell you guys something. If you want to make your lives easier for when you guys get to psych, keep this in mind when it comes to depression, and it's going to help you answer those depression questions. Depression, all depression is anger, resentment, hostility, all of those bad feelings turn towards self. That is what depression is. So one of the ways you know patient is getting better, the meds are working, is you'll get a test question that says something like the patient's been on this antidepressant for a couple of weeks. The spouse said they were going to come visit and they did not come visit. Now the patient is upset and throwing things. Guess what? That's actually a good thing. It's not a good thing that they're throwing things, but the fact that they're upset. Because back when they were in that depressive state, I'm not worthy. I'm not good enough. Of course, nobody wants to come visit me. But as the medications start working and that depression starts to lift, I'm worthy. How dare they say that they were going to come visit me and not show up? I'm valuable. I'm worth it. That's why I'm upset. Do you see what I'm saying, guys? So it's a good thing. Don't fall for it when you see it. I warned you. All right. MAOIs. These are antidepressants. SSRIs, those are our first line drugs that we use for depression. They block the reuptake of serotonin. They relieve depression. And they are not associated with anticholinergic or sympathomimetic adverse effects. TCAs, those are tricyclic antidepressants. They block the reuptake of norepinephrine and serotonin. They relieve depression, but they do have anticholinergic and sedative effects. Tyramine. This is an amine found in food that causes vasoconstriction and raises blood pressure. Ingesting foods high in tyramine while taking MAOIs poses a risk of severe hypertensive crisis. You need to know that. So you already know any patient that are taking MAOIs, they cannot eat foods that are high in tyramine. And MAOIs reacts with so many other medications. We'll get there. All right, how many drug cards do you already have for me? 3? Okay, so number 4 is going to be the TCAs. Amitriptyline, amoxicillin. You guys see the list? Number 5 are my MAOIs. Number 6, my SSRIs. And then number 7, my antidepressants. So next week, you guys are going to give me 7 drug cards.
Not the serotonin one?
No, you don't have to do that one.
What does it say on her antidepressants?
Oh, this drug, the bupropion, it helps with smoking cessation. when this question shows up on NCLEX, it's usually in relation, they'll give you a situation about a patient that has been smoking X packs per day for X amount of years. They come in with depression. Which medication do you expect the physician to order? It's usually that type of situation. So I put it here on the side so you guys can remember. All right, I'm turning the page. Okay, affect. Affect is a term that's used to refer to people's feelings in response to their environment, whether positive and pleasant or negative and unpleasant. I already told you guys what depression is. You guys can read all of that on your own. Let's talk about drug therapy. Antidepressants can be classified into 4 main groups. Your tricyclic antidepressants, those are your TCAs. Your monoamine oxidase inhibitors, those are your MAOIs. Your selective serotonin reuptake inhibitors, those are your SSRIs. And then your serotonin norepinephrine inhibitors, those are your SNRIs. So let's start with the TCAs. The TCAs, they all reduce the reuptake of 5-HT norepinephrine into the nerves. Because all TCAs are similarly effective, the choice of TCA depends on the individual response of the drug. A patient who does not respond to one TCA may respond to another drug from the same drug class. And then they give you the list of TCAs. Make sure you look at that on your own. Page 358. TCAs are indicated for the relief of symptoms of depression. The sedative effects of these drugs may make them more effective in patients whose depression is characterized by anxiety and sleep disturbances. The TCAs are anticholinergic. So remember that poem for the anticholinergics. Can't see, can't spit, can't pee, can't you know what? Okay. Contraindications and cautions. Allergy, recent MI, myelography within the previous 24 hours or in the next 24 hours. Here's why. Look at this. Because of a possible drug-drug interaction with the dye that's used in those studies. So you have to make sure that that patient has not had a myelography or any other study that uses a contrast dye in the past 24 hours, and they're not going to be getting one within the next 48 hours. Another contraindicated indication, concurrent use of MAOI. When I tell you the MAOIs are contraindicated with so many drugs, when we get to the MAOIs and you see the list, it's ridiculous. And that's why we don't put patients on MAOIs unless we absolutely have to, because the drug-drug interactions and the contraindications is just so much. So absolutely a contraindication for the TCAs is if the patient's on the MAOI. Matter of fact, if the patient's being switched from an MAOI to a TCA, weeks have to go by before we can put them on the TCA, because we have to make sure that that MAOI has been cleared from their system. Pregnancy and lactation, cardiovascular disease, angle closure glaucoma, urinary retention, hypertrophy, and you guys know why, because of those anticholinergic effects. Care should also be taken with psychiatric patients who may exhibit a worsening of psychosis or paranoia, with manic depressive patients who may shift to a manic state. There's a black box warning on all of the TCAs, bringing attention to a risk of suicidality, especially in children and adolescents and young adults. And that's across the board. That's not only for the TCAs. When it comes to the antidepressants, we have to be very careful, because I'm not sure of the chemistry of it. I don't know the science behind it. However, when it comes to children and very young adults, These antidepressants can have an opposite effect and give them these suicidal thoughts. So you have to monitor children and young adults much, much closer. You guys get me sick, I'm wringing your necks. Everyone's sick of this class. So I put NCLEX next to adolescents because that's shown up a lot of times when it comes to the antidepressant drugs. Make sure you know that. Caution should be used, and the amount of drug dispensed at any given time should be limited with potentially suicidal patients. And I wrote on the side, NCLEX DC only 2 to 3 days worth. So what happens is, if you allow that patient to be discharged with, you know, the normal 30-day supply, what do you think may happen when they get home? They take the whole 30-day supply, try to help themselves, right? So you're only going to let them get 2-3 days at the most because they need to follow up with their healthcare provider once they're discharged for refill, okay? Adverse effects of the TCAs. Sedation, sleep disturbance, fatigue, hallucination, disorientation, visual disturbances, difficulty concentrating, weakness, ataxia. Ataxia is when they're walking like they're drunk. And tremors may occur. And of course, anticholinergic effects. So all of those effects we see with the class of anticholinergic drugs apply to the TCAs. Cardiovascular effects include orthostatic hypotension, hypertension, arrhythmias, palpitations, etc. Abrupt cessation of all TCAs causes a withdrawal syndrome characterized by nausea, headache, vertigo, malaise, and nightmares. Should TCAs ever be stopped abruptly? No. Drug-drug interactions. If TCAs are given with cimetidine, fluoxetine, or ranitidine, an increase in TCA levels can result. The combination of TCAs and oral anticoagulants leads to a higher serum level of the anticoagulant, which means the patient can what? Clot too much or bleed too much? Bleed too much, hemorrhage, okay? And they'll have increased risk of bleeding. So we have to be careful with that. If TCAs are combined with sympathomimetics or clonidine, the risk of arrhythmia and hypertension is increased. The combination of TCAs with MAOIs leads to a risk of severe hyperpyretic crisis with severe convulsions, hypertensive episodes, and even death. Hyperpyretic crisis, that temperature increased to the point that their life is in danger, okay? This combination should be avoided. You never give a TCA with the MAOI because the MAOIs by themselves can put the patient at risk for hypertensive crisis. Okay? Nursing considerations for patients taking TCAs. Assess them for allergy, impaired liver function, glaucoma, BPH, cardiac dysfunction, GI obstruction, surgery, or myocardial infarction. Pregnancy and lactation. We're going to assess them for a history of seizure disorders or history of psychiatric problems or suicidal thoughts. Myelography within the past 24 hours or scheduled for the next 48 hours because remember it interacts with that dye, or patients taking MAOIs. All of those are contraindications. Implementation with rationale. You're going to limit drug access if the patient is suicidal. We don't want them to overdose. Maintain the initial dose for 4 to 8 weeks to evaluate the therapeutic effect, and you have to teach that to the patient. When it comes to these CNS, these psych drugs, it takes a couple weeks before we get a therapeutic effect in the bloodstream, right? So it's going to take a couple weeks before they start to feel better. If you don't teach them that, remember, depression is anger, hostility, resentment turned towards self. They're going to say, you know what? I knew it. I'm such a loser. This medication's working for everybody else, but it's not working for me. You have to teach them. It's going to take a couple weeks before you start to feel better, before you start feeling the therapeutic effects. Okay, a good 3-4 weeks, sometimes even more. You have to teach them that. You're going to switch to an oral form as soon as possible. Administer a major portion of the dose at bedtime if drowsiness and the anticholinergic effects are severe. Remember, they may be a fall risk. Safety. This drug must be discontinued slowly. The patient has to be weaned off. It should not be stopped abruptly. Key points. Affect is the term that refers to the feelings that people experience when they respond emotionally. But you as the nurse, when you're looking at that patient's affect, what are you looking for? Okay. Depression. Depression is an affective disorder characterized by inappropriate sadness, despair, hopelessness, turned towards who? Themselves. MAOIs. Not the first or even second choice, yes.
Do you mind just going over what you wrote on the sides for that second column there?
Right here?
Yeah.
I wrote towards self.
And then above.
Prevent falls and ASAP. So you want to switch to oral form as soon as possible. Because of the anticholinergic effects and drowsiness, you want to prevent falls and promote safety. All right, MAOIs. MAOIs are not our first, second, or even third choice when it comes to antidepressant. And you guys are about to find out why. All right, MAOIs, they irreversibly inhibit MAO, an enzyme that's found in nerves and other tissues. They're used rarely because they require a specific dietary regimen to prevent toxicity. Really, we only turn to the MAOIs when nothing else has worked. They require, there are some patients, however, who only seem to respond to these particular drugs, so they remain available. And they give you the list of MAOIs, make sure you know them. Blocking the breakdown of the biogenic amines, norepinephrine, dopamine, and 5-HT2, that's their action. The MAOIs are generally indicated for the treatment of the signs and symptoms of depression in patients who cannot tolerate or do not respond to other safer antidepressants. So that lets us know that we only turn to MAOIs if we have to. We're going to exhaust all our other options. Contraindications, and there are many. Allergy, pheochromocytoma, cardiovascular disease, known abnormal CNS vessels or defects, history of headaches, renal or hepatic impairment, myelography, did I say that right? Myelography? Myelography within the past 24 hours or in the next 48 hours, psychiatric patients who could be overstimulated or shift to a manic phase as a result of stimulation associated with the MAOIs or contraindications. Seizure disorders or hyperthyroidism are also contraindications. There's a black box warning on all drugs of this class, the MAOIs, to bring awareness to a possible risk of suicidality in patients using these drugs, especially with children, adolescents, and young adults. Care should also be taken with patients who are soon to undergo elective surgery because of the potential for unexpected effects with norepinephrine accumulation during the stress reaction with female patients who are pregnant or breastfeeding. Adverse reactions. The MAOIs are associated with some adverse effects, more of which are fatal, as in deadly, as in lethal, than other antidepressants. We have to be very careful when it comes to MAOIs. Dizziness, excitement, nervousness, mania, hyperreflexia, tremors, confusion, insomnia, agitation, and blurred vision may occur. MAOIs can cause liver toxicity. and they go over the other GI and cardiovascular effects. You guys can read that on your own. I'm going to bring this to your attention though. Look at this. Potentially fatal hypertensive crisis can occur. This last condition is characterized by, you have to know this, it will be a select all that applies on the test that I give you because it's been seen on the NCLEX as select all that apply. Here's the list. Occipital headaches, palpitations, neck stiffness, nausea, vomiting, sweating, dilated pupils, photophobia, tachycardia, and chest pain. Those are your signs and symptoms of the hypertensive crisis, guys. It may progress to intracranial bleeding and even a fatal stroke. So if the patient is on an MAOI and you're seeing these signs and symptoms, you're going to withhold that next dose and you're going to call the physician immediately. Okay? Drug-drug interactions. Don't hate me because almost everything is highlighted in this area. The reason everything is almost highlighted in this area is all of this stuff is important. It's been seen on NCLEX, so I have to give it to you. Don't shoot the messenger. All right, so drug interactions with other antidepressants include, on top of that list is hypertensive crisis. Whenever you guys see a test question about an MAOI, that needs to be one of the first things that should be going on in the back of your mind, hypertensive crisis. Coma, severe convulsions with TCAs, and increased risk of potentially life-threatening serotonin syndrome. We're going to get to that in a second when we get to the SSRIs. The exact timing will vary, but a period of, look at this, 6 weeks after stopping an SSRI may be needed before beginning an MAOI. And the reason for that, guys, if the patient stops taking an MAOI, well, the MAOI is still in their bloodstream. It's going to take a solid 6 weeks before it's completely cleared that if we're going to start the patient on an SSRI, that they can start that SSRI. Because if we don't do that, the MAOI is still in their bloodstream. And now they have SSRI in their bloodstream, they can get serotonin syndrome. What are those signs and symptoms of serotonin syndrome? I'll give it to you. You guys ready? Increased heart rate, increased blood pressure, muscle rigidity, confusion, agitation, restlessness, sweating. What's the other word for sweating? Starts with a D? Diaphoresis. Very good, diaphoresis. Or diarrhea. So if you get a test question about a patient that's on an SSRI and you're seeing the signs and symptoms, you need to be thinking serotonin syndrome. Okay, and this is a potentially fatal syndrome. Okay, moving on.
See, Jenny's is doing the same thing. Welcome to my club.
No, I'm taking this. This is 4 pages.
Yeah.
Yeah, I'm taking this to Office Depot and I'm gonna have them bind it up. This is ridiculous.
Oh, they can do it?
Oh yeah, yeah.
My folks don't. Yeah, it's on.
They charge like $15, $16 and they bind it for you.
That's not bad.
All right, page 362. Let's go over the drug-food interactions and then we'll cover this table. Food-drug interactions, tyramine and other pressor amines that are found in food which are normally broken down by MAO enzymes in the GI tract may be absorbed in high concentrations in the presence of MAOIs, resulting in increased blood pressure. And this is why the patients need to stay away from foods that are high in tyramine. Patients who take MAOIs should avoid tyramine-containing foods. What are they? Here it is, guys. You need to know them. Foods high in tyramine. Aged cheeses, such as cheddar cheese, blue cheese, Swiss cheese. fermented meats, fish, poultry, brewer's yeast, red wine. The ones I underline, guys, are the ones that show up on NCLEX the most, but I don't write that test, so make sure you know all of them. I'm just underline the ones that show up the most, okay? Red wines, smoked or pickled meats, salami, sausage, pepperoni, soy sauce, all of those are no-go. If the patient is taking MAOIs, they cannot have any of these. All right, nursing considerations for patients receiving MAOIs. Again, we're going to assess them for allergies, kidney function, impaired liver function, cardiac dysfunction, GI obstruction, surgery, including elective surgery, seizure disorder, psychiatric conditions, or suicidality, occurrence of myelography within the past 24 hours or in the next 48 hours, pregnancy or breastfeeding. Implementation and rationale. You're going to limit access to the drug for the suicidal patient because we don't want them to overdose. Monitor for the patient for 2 to 6 weeks to ascertain the onset of the full therapeutic effects. And you have to also teach them that teach the patient that it can take a full 2 to 6 weeks before they start to feel better. Nothing is wrong with them. The healthcare provider is not going to switch them class of drugs until it's been at least 6 weeks because they know it'll take that long before we may see effects. Monitor the blood pressure and orthostatic blood pressure carefully to arrange for a slower increase in dose as needed for patients who show a tendency towards hypotension. Monitor liver function. So we're going to be looking at that ALT. We're going to be looking at the AST, right? We're going to be looking at those liver function tests. Discontinue drugs. You're going to hold that medication and monitor the patient carefully and call the doctor at any complaint of severe headache. Severe headache, we're going to be thinking what? Blood pressure. We're going to hold that medication, take that blood pressure immediately. Hopefully they're not having a stroke. Have phentolamine or another adrenergic blocker on standby as treatment in case the patient actually is going through hypertensive crisis. Provide a list of potential drug-food interactions that could cause severe toxicity. Provide a diet that is low in tyramine-containing foods. Key points. I did it. Patients taking MAOIs need to avoid foods high in tyramine and prevent serious increases in blood pressure and hypertensive crisis. All right, next, SSRIs. SSRIs, these are our #1 choice when it comes to antidepressants. A happy face next to it. We love our SSRIs. Okay, so SSRIs, antidepressant drugs that specifically block the reuptake of 5-HT with little to no known effect on norepinephrine. Because SSRIs do not have the many adverse effects associated with TCAs and MAOIs, they are a better choice for many patients. Make sure you know all of the drugs that fall into the SSRI class. SSRIs are indicated for the treatment of depression, OCD, panic disorders, bulimia, premenstrual dysphoric disorder, PTSD, social phobia, social anxiety disorders. You guys have to know that list of the other disorders that we use SSRIs to treat. A period of up to 4 weeks is necessary for realization of the full therapeutic effect. You must teach this to the patient. Because remember, depression is anger, resentment, hostility turned towards self. So if you don't teach that to them, they're going to say, see, I'm such a loser. I knew it. This medication is not working for me, but it's working for everyone else. Contraindications and cautions. Allergy to SSRIs, hepatic dysfunction, severely depressed or suicidal patients, again, especially children, adolescents, and young adults. Pregnancy, breastfeeding. Adverse effects, the CNS effects such as headache, drowsiness, dizziness, GI effects such as nausea, vomiting, diarrhea, GU effects such as painful menstruation, cystitis, respiratory changes may include cough, upper respiratory infections. SSRIs may also cause serious intraocular pressure changes if used in patients with untreated narrow angle glaucoma. Other reported effects are sweating, rash, fever, and pruritus. Recent studies have linked the incidence of suicidal ideation and suicidal attempts to the use of these drugs in pediatric and adolescent patients. Yes.
How come all the antidepressant drugs are for like kids? Why does it make them want to commit suicide in adults?
I just told you guys I don't know the science behind it. I said I have no clue. I don't know the science behind it. I don't know. But definitely the children, the adolescents, and young adults that are on antidepressants, they need to be followed much, much more closely. So the regular adult, that outpatient, you know, they'd be seeing their psychiatrist once a month for refill. The children, the adolescents, they're going once a week or once every 2 weeks. And the parents are constantly taught to make sure that they keep those medications out of the reach of the children, locked away because of the possibility of suicidal ideation. Let me just say this, like I said, I have no science behind it at all. However, when you guys get to when you guys get to psych, one of the things that you're going to learn is that the developmental task of the adolescent is identity, finding out who they are, right? And the way that they find out who they are is by their social groups. That's why with the teenagers, the most important thing to them are their friends. They don't want to be different in any way. They don't want to stick out. But at the same time, they want to be their own person, and they want to be an individual, and they want to be independent, right? So what I'm thinking is, at least with the adolescent, there's a lot of pressure. Like, at least when I grew up, oh my gosh, half of the things that I did, my goodness, if it was caught on video. But now everything, you know, everything is Instagram and Facebook and TikTok, and you're seeing, I remember there was a time where 11 and 12 and 13-year-olds were allowed to be preteens. It's like you go from 10 to 21. You know what I mean? It's a lot of pressure. So I'm just thinking with social media and just the pressure that the adolescents feel because you do one thing wrong and you're outcasted, right? I think that may have something to do with it, but I don't have any science behind it. All right, clinically important drug-drug interactions for the SSRIs. You see, I have a lot of stars. I have a lot of NCLEX. I have a lot of underlined, so make sure you pay attention. Because of the risk of serotonin syndrome, there goes that serotonin syndrome again. Because of the risk of serotonin syndrome and SSRIs are used with MAOIs, this combination should be avoided. The patient cannot take SSRIs with MAOIs because of the risk of serotonin syndrome. The exact timing will vary, but a period of 6 weeks after stopping an SSRI may be needed before beginning therapy with an MAOI. You need to know this. Serotonin syndrome, a serious to potentially fatal reaction, can occur if these drugs are combined with any drug or, look at this guys, herb. Any drug or herb that increases 5-HT levels, other SSRI, serotonin norepinephrine reuptake inhibitors, St. John's worts, or triptans. There's an increased risk of bleeding if these drugs are combined with aspirin, NSAIDs, antiplatelet drugs, or drugs that affect coagulation. You need to know that. Herbal and alternative therapies. Serotonin syndrome, as well as an increased sensitivity to light if they're taken with St. John's worts. Because this herbal therapy is often used to self-treat depression, it's important to forewarn, to teach the patient, any patient who's taking an SSRI should not combine it with St. John's worts. So we saw it in text up here. Now they're saying the same thing in the box below. That's definitely important to know. Also caution patients that there's an increased risk of seizures if evening primrose is used with antidepressants, and patients should be cautioned against this combination. Interactions have also been reported when antidepressants are combined with, how do I pronounce this herb? Is it ginkgo or ginkgo? Ginkgo, thank you. Ginkgo, ginseng, and valerian. Patients should be cautioned against using these herbs while taking antidepressants. You see this drug fluoxetine, which is an SSRI? NCLEX many times has asked about this drug specifically. And the reason for that, even though it's a great drug for depression because it's SSRI, right? But it also helps with bulimia. So if a patient is diagnosed with depression, but they also have a history of bulimia, you would expect this to be ordered. Okay? Fluoxetine. I know, I'm so sorry. Don't shoot the messenger, guys. All right, nursing considerations for patients receiving SSRIs or SNRIs. Contraindications: allergies, severe depression or suicidality, angle closure glaucoma, bipolar disorder, impaired liver or kidney dysfunction. Implementation and rationale: arrange for lower doses in the adults and the geriatric patients, because remember, the geriatric patients, their liver and their kidneys are not functioning the way they used to, so they're at higher risk for toxic levels, so they need less of the medication than your regular healthy adult. Okay, you're going to monitor the patient for up to 4 weeks to make sure that it's working before the dose gets adjusted. It takes at least 4 weeks, a good 4 weeks before we see that therapeutic level. Establish suicide precautions for severely depressed patients and limit the quantity of the drug. Want to know what those suicide precautions are? One-on-ones. That's your suicide precaution. Yes. You're going to administer the drug once a day. When? In the morning. Because remember, this patient has depression. We're trying to lift them out of depression. We're trying to lift up their mood. So it's not something you want to give to them at night. You're going to give it to them in the morning. Can't take it while you're pregnant. So we're going to teach women of childbearing age to use a barrier contraceptive such as what? A condom. It's almost lunchtime, guys. Stay with me. I'm dying out here. Remember, the SSRIs can cause fetal abnormalities, so they can't be on it while they're pregnant. Provide comfort measures to help the patient tolerate drug effects. This may include voiding before dosing, instituting a bowel program, taking food with the drug if they get GI upset. Environmental controls such as lighting, temperature, stimuli. Instruct patients about the need for periodic monitoring and evaluation. You're going to monitor for adverse effects of SSRIs, such as sedation, dizziness, etc. Remember, guys, there is a risk of serotonin syndrome with both classifications of medications. Don't forget those signs and symptoms. Teach them the importance of avoiding pregnancy. Make sure they're using a barrier contraceptive. Okay, so this is a case study about a patient that's been prescribed fluoxetine, which is an SSRI. You're going to remind the patient that it may take as long as 4 weeks before they get therapeutic levels. The drug needs to be given in the morning. In the morning, have them avoid before giving them the medication, side rails for safety, teach them that they can't get pregnant on the medication, so they have to use barrier contraceptives, limit dosage with potentially suicidal patients, very important. You see, I put NCLEX next to it. Again, 4 weeks, there's a 4-week delay. You need to know that. Can I turn the page out? Yeah. The drug should be taken once a day in the morning. If you're having stomach upset, the dose can be divided. Again, how many times have we seen this, guys? It may take as long as 4 weeks before you feel the full effects of the drugs. We've seen this a million times. Common side effects of SSRI includes dizziness, drowsiness, nervousness, insomnia, so we're going to provide safety measures. Sexual dysfunction and flu-like symptoms. These effects may be temporary. You have to teach that to the patient, especially men. And the reason I said especially men, because they will stop taking that medication. So you have to teach them that it's temporary. And consult with your healthcare provider if they become bothersome. Tell your doctors, nurses, and other healthcare providers that you're taking this drug. If the patient's on SSRIs, everyone on the healthcare team needs to know. Teach them not to take that drug during pregnancy and to use barrier contraceptives. Key points. After the key points, guys, we'll stop and we'll continue next week because I can tell you flatlined on me. We do? Okay, so let's finish up. Okay, key points. The SSRIs prevent the reuptake of serotonin. The SSRIs are not associated with many of the CNS, cardiovascular, and anticholinergic effects of other antidepressants, and that's why SSRIs are our first-line drug choices for antidepressants. Combination of SSRIs with other SSRIs or with other drugs that are known to increase 5-HT levels increase the risk of serotonin syndrome. Caution should be used if any of these drugs are combined with other drugs known to affect bleeding. All right, let's talk about SNRIs, serotonin norepinephrine inhibitors. The SNRIs work by decreasing the neuronal reuptake of both serotonin and norepinephrine and more weakly inhibit dopamine. This classification of medications may be more effective for treating depression than other antidepressants for some patients. They may even be used before MAOIs or TCAs due to the fewer side effects. And I put NCLEX next to it because you need to know that. As with other antidepressants, these drugs have a black box warning to be alert for possibility of increased suicidality, especially in children, adolescents, and young adults. And here are the list of your SNRIs. There are 4 of them. Make sure you know them. All right, therapeutic effects and indications. This is breaking my heart. The SNRIs increase the levels of both serotonin and norepinephrine in the synaptic cleft. They do not inhibit MAO. They often will have therapeutic effect often will not have a therapeutic effect for 4 to 6 weeks. So you have to teach the patient, it's going to be a solid 4 to 6 weeks before you start to feel better. Client assessment. It's important to know whether the client is in the process of quitting smoking, and that's for this medication, the bupropion. Remember I talked to you guys about that? This drug is effective in clients undergoing smoking cessation. You need to know that. Just like the SSRI fluoxetine, you need to remember bulimia. This bupropion, you need to remember for smoking cessation. All right, contraindications and cautions. Presence of allergy. The drug should not be used in conjunction with MAOIs. Why? Because of risk of hypertensive crisis or serotonin syndrome. Caution should be used with severely depressed or suicidal patients, especially children, adolescents, and young adults. Patients should be screened for bipolar disorder and risk of seizures before starting these medications. Down. SNRIs are present in breast milk, so the mother may need to select a different method of breastfeeding. Some of adverse effects. Some of the most common side effects are nausea, constipation, higher heart rates. Somebody look this word up. Hyperhidrosis. Sweating?
I think so.
Look it up to make sure.
I think it was like sweaty hands and like really sweaty underarms or something.
I think so.
Sweating.
That's right. My brother had that. Okay. That excessive sweating, like the arms, the armpits, the hands, the armpits. Thank you. Erectile dysfunction, tachycardia, vomiting, palpitations. There's a risk of serotonin syndrome, hypertension, abnormal bleeding, angle closure glaucoma, and urinary retention. Drug-drug interactions. When it comes to the SNRIs, because of increased risk of serotonin syndrome, when SNRIs are used with MAOIs, the combination should be avoided. Any substance that is serotonergic, such as your triptans, your tricyclics, fentanyl, lithium, tramadol, tryptophan, buspirone, amphetamines, and St. John's worts, they can increase the risk of serotonin syndrome. Make sure you know that list, guys. The drugs that can increase the risk of serotonin syndrome. There's increased risk of bleeding if the medications are combined with aspirin, NSAIDs, antiplatelet drugs, or other drugs that affect coagulation. Key points. The SNRIs prevent the reuptake of primarily serotonin and norepinephrine. The side effects of this classification are related to the potential serotonergic and non-adrenergic activity. They have a black box warning about suicidal thoughts and behaviors in children, adolescents, and young adults. We're almost done. Other antidepressants, again, bupropion, that's your Wellbutrin or Zyban, weakly blocks the reuptake of norepinephrine, 5-HT, and dopamine. At lower doses, this drug is effective in smoking cessation. You guys absolutely have to know that smoking part. When you see that medication, I need that to be the first thing going through your mind. It's a great antidepressant, but it also helps for patients that are trying to get off the tobacco. It does enter breast milk and should not be used by nursing mothers. Page 370. Remember the smoking cessation for the bupropion, and then summary. The adverse effects of TCAs are sedating and anticholinergic. Those of MAOIs are CNS related and sympathomimetic. The adverse effects of SSRIs are fewer, but they do cause CNS changes. The SNRIs have serotonergic and non-adrenergic effects. All the SSRIs, the SNRIs, the MAOIs, the TCAs, all of those antidepressant drugs have a black box warning of the risk of suicidality, especially in children, adolescents, and young adults.